Hi, it's Matthew Links and welcome to this short video on cancer immunotherapy with checkpoint inhibitors for primary care. This is not intended to be a comprehensive coverage of the topic, but just to let you know what you need to understand in order to look after a patient on one of these treatments in your practice. The first thing to understand is that there are different types of immunotherapy. I'm not going to talk about antibody-targeted therapies such as trastuzumab directed against HER2 or bevacizumab, or about cellular immunotherapies such as CAR T cells. This talk is restricted to checkpoint inhibitors, that drugs that activate T cell response against the cancer by targeting one of the pathways in immune surveillance, such as PD-L1, with drugs such as pembrolizumab, or CTLA-4 with drugs as ipilimumab. These are both different ways of activating the immune system to fight against the cancer. The most important thing to understand is that immune adverse effects can affect any organ, and this relates to difficulty in diagnosing these problems. The most common ones are pneumonitis, colitis, hepatitis, or endocrinopathies such as hypo or hyperthyroidism, but really any part of the body can be affected. The critical issue, therefore, is to suspect it. And in order to do this, you need three things. First of all, you need to know the patient's on immunotherapy with a checkpoint inhibitor, and this is difficult because of the rapid development of new drugs. You can't really get past a practice of Googling unfamiliar drugs to understand what the mechanism of action is. The second issue is realising that this presentation could be an immune adverse event, and this is particularly difficult with subtle presentations such as adrenal insufficiency or encephalitis, but it also highlights the difficulties of blaming distractors, such as blaming the colitis on the laxatives or the pneumonitis on the lung cancer. This creates confusion, and really the priority is to suspect that the drug may be the cause, because you don't want to miss a reversible, treatable and potentially serious complication. The third thing is to access support, and for mild symptoms this might be symptomatic management of a rash, but moderate symptoms require escalation to oncology. It's difficult to simplify the grading of immune adverse effects, as the definitions of what's grade 1 and what's grade 2 differs from every toxicity. But anything more than mild is grade 2, such as something that requires an intervention or interferes with function, and these toxicities need escalation to oncology and consideration of urgent high-dose steroids and withholding treatment. For simple toxicities or grade 1 toxicities, the issues, apart from symptomatic management, are reinforcing the education, thinking about alternate causes of their toxicity, and making a plan for support if it escalates. We certainly do see grade 4 life-threatening toxicities, and these may require additional immunosuppression like infliximab. Here's a slide summarising a clinical practice guideline for immune-related gastrointestinal toxicities, and you can see that it's quite complex. It starts with grading the symptom, and that even more than 4 liquid stools a day or abdominal pain can bump up a toxicity into moderate, and moderate toxicities lasting more than a few days will require steroids. In longitudinal care, the issues are different, and 2 particular issues I'd highlight are prognosis and unmet needs. Immunotherapies have introduced a lot of uncertainty into the prognosis of cancers that we previously knew had a poor prognosis. Some incurable cancers are now having prolonged remissions, but often the long-term follow-up is ongoing, and we're not entirely certain how frequent that is. The duration of therapy required is often uncertain, and the bottom line is that most patients will still relapse. So there's been hope created with the prognosis of many cancers, but caution is required. The other issue in chronic care that will lead to presentation is unmet needs, either physical unmet needs, and it's important to remember that most patient presentations will be related to cancer symptoms and require supportive care as per usual. It's also important to remember that with all cancer patients, apart from physical unmet needs, there's psychosocial, spiritual, cultural and practical issues benefit from ongoing assessment and mobilisation of support, and there's a lot that can be done in this regard in primary care. A caveat or warning, I would encourage you to avoid steroids without good reason. These treatments work by harnessing the immune system to fight against the cancer, and steroids will inhibit that. So we don't want these patients to be having steroids without a really good reason. If in doubt, I would just encourage you to have a low threshold for contacting local oncology department oncologists for support. I've included a few references to help. I would highly recommend the Everq Immunotherapy for GP fact sheet or management guidelines from the Everq website for particular treatments. I also recommend the Esmo management guidelines that have some good flow charts, and there's a nice RACGP article on immunotherapy. So I hope that's helpful. This is a rapidly changing area, difficult to keep up, but one that we're seeing more and more of and needing more and more assistance in managing these patients. Thanks for your attention.